Good morning, and welcome to this week's episode of the Ask Dr. Murphy series. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Doing just fine.
Dr. Robert Murphy is the Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week here on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be answering viewer submitted questions, addressing the latest headlines, and our lone US COVID statistic through today, September 19th. We invite you to submit any questions or suggested topics down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Starting with the COVID statistic, average COVID deaths per day in the last reported week were 136 daily. The same week in 2023, we saw 152 daily COVID deaths. Dr. Murphy, your reaction to that number as well as the general state of COVID in the country.
Well, it's almost what we were doing last year. That ends up being almost 50,000 cases per year at that rate. Remember, it was just a couple months ago that we had 20 deaths per day. So this is the result of this summer bump. And there is still very high viral activity when you look at the wastewater sampling, particularly here in the Midwest. The Midwest and the West remain, quote, very high. Other parts of the country have gone down to high. So the bump is going down, but we're still at the top of the bump. So there's people getting COVID all the time. Hospitalization levels, although people are coming into the hospital, they've actually been declining since August. So the death rate is the people that can't get out of the hospital. Obviously, they're too sick. And that's what it's related to. But that's the status right now. It's still a lot of COVID out there.
Mm-hmm. And I understand there's been a survey regarding people's intentions for both the COVID vaccine and the flu vaccine. Can you tell us about those numbers and why it's so important to get those vaccinations?
Well, the best way to deal with a potentially lethal disease on a public health wide basis is to prevent it. And the best way to prevent it is to be immunized against it. So this is a flu vaccine or a COVID vaccine. And remember, these viruses change. They mutate. They're different every year. So the flu virus and the COVID vaccine is changing at least once a year. So a study done at Ohio State University looked at, asked people, and in the survey, they found that 56% of the respondents said they were going to get a flu vaccine. Now, remember, flu vaccine is approved for every single person 6 months and older. And only 43% said they were going to get the new COVID vaccine. So if you've had the older vaccines, it's like that kind of virus doesn't even exist anymore. This new one is geared toward the circulating strains right now. So, I mean, frankly, it's pathetic. The vaccine uptake here is so low. And there's a lot of reasons for that. But there's really no excuse if you want to avoid getting these infections. And don't forget, even if you're a healthy, younger person, when you get COVID or you get influenza, you can spread it to other people that are not so lucky as you. They could be older. It could be your grandmother. It could be somebody you visit in a hospital or a nursing home or something like that. So if everybody gets vaccinated, the whole problem with those diseases goes way, way, way down. But at these kind of rates, it's pretty bad.
Mm-hmm. And digging into some of the results that we saw out of the 2023-2024 flu season specifically, I understand there was an upsetting record match in terms of some of the deaths there. Can you tell us about that?
Yeah, so the last week they reported 2 additional deaths from flu in children. The total number in this current, in the 23-24 flu season, matched a previous high of 199 pediatric deaths in a single season. And of the 158 children who were eligible to receive the vaccine and had known vaccine status, 83% were not fully vaccinated. This is the risk. And of the 199 fatal cases, 73 were younger than 5 years old, and 126 were aged 5 to 17. And on top of everything else, the uptake rate for the flu vaccine in children actually has declined by a few percentage points. It's just very sad. I mean, seeing a sick child with the flu in the hospital, and almost 200 deaths per year that are preventable. It's just, hopefully people will get the message and make sure their kids are vaccinated.
Absolutely. And before we move on to our submitted questions this week, I saw another study this week that was around metformin, those who take that drug for diabetes and long COVID. Can you tell us
Right.
the results of that study?
Yeah, so metformin is an old drug. It's a generic drug now, used for part of the treatment in diabetes. And a study last year showed that it may reduce the effects of long COVID by 40%. So that was kind of a surprise. And so they did a larger study and looked at it. And it wasn't really a study, but I mean, it's a study, but it wasn't like they were enrolling patients in a study, but they looked at the records of 38 million Americans. They looked at their health records and found approximately 76,000 people taking metformin for their diabetes, and another 13,500 from those that were not taking metformin, but were using other type of diabetes medicine. So they had diabetes, but they weren't on metformin. Now, this is not a randomized study, but this is a big number. And they were specifically looking at how many patients died or got diagnosed with long COVID. And they found that the patients on the metformin, just like the other study I talked about, had 13 to 21% lower incidence of long COVID or death. They combined the endpoints compared to the non-metformin group. Nobody knows why this is happening. But I mean, it's certainly interesting. These are big numbers that makes the study more powerful. So I think we'll see a lot more attention to metformin in the future.
Absolutely. Something we will look for more data on as it comes out.
It's a prescription drug, by the way.
Mhm. Getting into our viewer submitted questions for the day, our first comes from a longtime viewer who is wondering if there are more infectious disease outbreaks and epidemics today compared to, say, 20 years ago. Seems like there's a remarkable increase, but they don't know if that's just because, we have all the media and the news and we can hear about things, or if those outbreak numbers have increased. Can you fill us in a little bit on this paradox?
Yeah, we've had this before, and the answer is the same. It's really an excellent question because it's very complicated to examine this. But epidemiologists have looked at it very closely, and here's the current scientific thinking. It's a variety of factors. It's like, why does an airplane crash? It's never one thing. It's always three things. The pilot's a little off that day, the weather is bad, and equipment failure. You have it's always three things because there's redundancy in all these systems and stuff. And the same is true here. So number one is that our public knowledge of outbreaks is much greater and faster now than ever. We're going to talk about a little outbreak that's happening here with the virus referred to as D68 at the end of the discussion today. And that's an example of what's going on. But so the public knowledge is greater. So that can, if you look, you can find. But pandemics are definitely increasing. The epidemiologists are clear. This is not just better publicity. And the factors are increased global travel, increased local travel, urbanization, climate change. Climate change is expanding the area where many of the vectors, the mosquitoes and midges and whatever, where they live, and they can help transmit the disease. They're increasing. Increase human-animal contact. And a global shortage of health workers, so that when epidemics start, there's nobody there to like take care of them. I mean, look at the monkeypox thing, the Mpox thing. You know, they've had those vaccines now for a week. They don't have enough people on the ground to actually get it out there like immediately. You know, it's really, really challenging. So you put all that together, and yes, pandemics will be more frequent.
Mm-hmm.
Great.
Lots of really interesting stuff there. A really, really excellent question.
Mm-hmm.
Our second one comes from another viewer who has been watching our episodes and has been hearing us talk about co-administration of the current flu and COVID vaccines. Is there enough of an improved immune response to be worth, getting that sometimes nasty reaction? And they have also heard that mainly in older or elderly patients that there was a small risk of stroke from that co-administration. Can you tell us about the current recommendations for these two vaccines?
Right. So a couple things to keep in mind. Taking the COVID vaccine or flu vaccine or whatever vaccine, whether you take them together or you take them apart, take them. That is really going to help. And so that's a truism. So, if you put them together, maybe it's a little better. If you have them apart, whatever. It doesn't really make all that much difference. You have to take the vaccine. Don't worry yourself that much about should I take it together or not. But I'll tell you some interesting data if you do take it together. The other thing is, yes, vaccines, medicines, aspirin, driving your car, all have risks. How much risk are you willing to take? For anything, for walking out the door, for going to school. Being in a classroom now is a risk. The numbers, the risk, are actually very, very low for having a bad event. Like this person is talking about what they read, which there were several strokes in people who had a vaccine in an elderly population that has other medical problems. And we know that those people have strokes. There's a rate that they're just going to have a stroke anyway. So, two things. If you do take the vaccines together, there is studies have shown, very sophisticated studies have shown that the immunologic response to the COVID was higher. This is a blood test measurement. Whether this means anything really significant, I don't know, but that's how we measure vaccine effectiveness, by the immune response. So I'm a believer that if you take them on the same day, you're going to have some side effects, the local side effects. It's considered safe and approved, but I think you might get a little more jazzy immunologic response if you take them together. It mostly works on the improved COVID response. The downside that they talked about with these strokes, it was reported to the U.S. Food and Drug Administration, the FDA, that in older adults, in co-administered patients, there were 3 strokes per 100,000 instances. So we're not even 100% sure if they're related, but even if they are, that is the risk. That would be the highest that it would be. So, 1 in, 33,000 people would maybe have a stroke after this. We don't even know if that in this population, this elderly population that has a lot of underlying diseases, we don't even know what the risk is not zero for having a stroke. So, nobody can tell you that the vaccine didn't do it, and the immunologic response may have triggered something. But that risk is way lower than the chance of what's going to happen to you if you get influenza. If you actually get sick, your chance of dying is way greater than that. So you always, it's a risk-benefit ratio, but that's for everything. It is not just vaccines. It's for every medication you take. Every kind of action you do, there's always some kind of outcome that is, dangerous. Driving in a car. You can have an accident. You could kill somebody or you could get killed. It's just, it falls into that everyday kind of level of risk. So you've got to make your decision. And I would rather not get sick. So.
Now, our final question today comes from the same viewer who added on. They were wondering what the current studies have shown about the length of immunity after COVID.
Nothing has changed. COVID is causes an immune response when you get it, and that immune response, for some reason, disappears over time, and it starts to go down after 3 to 4 months. So it doesn't last very long. So that's why the vaccines, they work really good for a couple months, and then they start to go away. That's why you have to keep doing these boosters. So every time you get COVID, and every time you have a booster or another vaccine, because they're technically not boosters because they're actually different vaccines, all that just keeps adding to your immunity. And that's why the overall cases, even though there's a lot of cases, the overall death rate is not as high as it was at the beginning of the pandemic when nobody had any immunity. And now we have treatments, and we know how to take care of people better, and the hospitals are not overwhelmed with cases. So it's 3 to 4 months, but you got to keep up with the shots annually. And your benefit, it will benefit people more at risk for hospitalization. So we've gone through those risk factors before. It's primarily driven by age. The older you are, the more risk. Then a slew of underlying diseases, any kind of cardiac disease, any kind of lung disease, any kind of neurologic disease. If you have underlying diseases, that is also going to increase your risk. So it's age and underlying diseases.
Very important. And thank you very much to our viewers for sending in their questions.
Good
We'd
question.
love to hear. You have very good questions. We love to hear from you. So if anyone has any questions or suggested topics, please feel free to send them our way. But moving into our headlines for today, the first big story is regarding the avian flu here in the US. Last week, we talked about a bit of an alarming human case, and we've now learned that there was a second. Can you remind us of the first one, tell us about this second one, and the avian flu in general?
So there's a case of a Missouri adult who came down with flu, and it turned out to be avian flu. And this person did not work with poultry or in a dairy farm, was not anything to do with agriculture. So no contact with birds or cattle. And the first 13 cases of avian flu were either bird handlers or people that worked on dairy farms. So everyone was concerned, and they did two things. They sequenced the virus. They found out it was the same virus that is affecting the cattle. But this person had no contact with cattle or milk. Then they find out that a person who lived in the household of that person also got sick. But they didn't tell anybody. And the person recovered. And now they can't find any virus in that person. So there could be a second case. Now, so they're still calling it a one-off, and that there's no epidemiological evidence at this time to support person-to-person transmission. But there's a big caveat there. Although the risk remains low today, I think the correct answer is that we don't know. This is an unknown. And that, this has got to be watched very closely if this is going to start popping up. If you remember at the beginning of the COVID, I remember there was one person in Arlington Heights. who had COVID. Nobody really thought too much about it. Look what happened. But we'll see what happens with this, if this virus has learned how to transmit person to person. So we don't know.
Yes. The alarm bells are ringing in our heads, but we're trying to stay calm until we have all the information. Now, our next story, another big outbreak we have been talking about. There's finally been some positive movement for the Jynneos Mpox vaccine. Can you tell us what happened this week?
So the WHO cleared the Bavarian Nordic company vaccine for Mpox. This makes it a lot easier to get those vaccines into the country. And this was a bureaucratic, delay that is really inexcusable, frankly. I'm sorry. They were already going around that by making deals directly with the company, and the United States and France were sending vaccines anyway. But this gets now the whole machine going. And so a couple 100,000 doses have already gone, and millions more are going to go. And there's a Japanese manufacturer that's also being considered. And just to remind people that more than 21,000 people are suspected to have confirmed or suspected Mpox cases, with 700 deaths this year alone, and more than half of them have been in children. Now, all this is going on. Vaccines went last week, and now millions more are going to go. Not one of them has been administered in the Congo. It's not like you can just deliver it and just people run to the airport and get the vaccine. There's a whole system in place. This is true anywhere. You have a supply chain, logistical issue, and whatever. And that's all being set up, and they think that they will be able to actually administer the vaccines by October 2nd, or 2 weeks from now.
Yeah, like you mentioned with the pandemic outbreak frequency question, a lack of global health workers does not help this situation get
Absolutely.
moving.
It's just amazing with this. And so 2 million doses can be supplied this year, an additional 11 million in 2025. And the Africa CDC says they need at least 10 million doses to tamp this down. So the machine is going, but it's kind of creaking along. But at least things are starting to happen.
We will keep our eyes on that as that machine starts to fire up and hopefully is running very soon. But looking to the future, something that hopefully can prevent situations and delays like this, the NIH has finally established the Pandemic Preparedness Network. Can you tell us about that and about their funding and what they hope to do?
Yeah, this is actually really great news. What the NIH is all about research, and you've got to figure out how to identify the diseases, how to test for them, how to treat them. It's the science side of it. So they're committed to $100 million a year to this network. The network is called the Research and Development of Vaccines and Monoclonal Antibodies for Pandemic Preparedness Network. It's referred to as REVAMP. That's the acronym. And this is great. This is really a big step in the right direction, and congratulations to them to get this off the ground. They're going to be studying a variety of diseases that have potential pandemic potential. Not only coronaviruses like COVID, but Crimea Congo hemorrhagic fever virus, Lassa fever, dengue, we've talked about many times, yellow fever, still prevalent in many African countries, measles, mumps, Nipah, encephalitis, we've mentioned. These are just some of the ones that can pop up that have the potential to really cause a big problem. And it's just a huge step in the right direction, so they should be congratulated. You should be happy that your government is investing in this kind of work, because the best thing is to be prepared.
Prevention, the best step. Now, our last story today, something that I'm unfamiliar with, but that has been popping up in the news. Enterovirus D68. Can you tell us what it is and why it's been in the news lately?
Yeah, enterovirus, this popped up just a couple days ago. It's a very common virus. It's transmitted person to person. It's highly contagious. It's a respiratory virus. Most people that get it have no symptoms or they're very mild. Nobody knows. However, in kids, especially if they've never been exposed to this enterovirus D68 before, can get this condition called AFM, or acute flaccid myelopathy. It's like polio. So this virus is related to the polio virus, but it's not polio, all right? But these young kids can get this, and it's it's scary. It's very scary. So there's been some cases of this, not with the AFM, but just this enterovirus D68. So everyone gets nervous when they see it. There's been some cases reported in Missouri and Illinois, including the University of Chicago here on the south side, had tested 11 out of 14 people they tested were positive for D68. So I think those kids were sick enough to either be in the hospital or be considered for admission, but they got tested. I don't know any more about it down there, but they looked in the wastewater. We looked for COVID there too. We're looking for all sorts of stuff in wastewater, and they're finding moderate levels around the country. So it is floating around out there, and it's we don't mention it to really. There's no treatment. There's no vaccine, and the point is that if your kid is sick, really sick, they need to get evaluated for this. There's no easy test for this, but the state and city health departments and the CDC can test. So they would know how to test for it. So it's just kind of an awareness need at this particular point.
Yeah. Doctors need to know that they could be testing for something like this or that they should be testing for
Right.
something like this.
Particularly if there's any neurologic problems associated with the respiratory thing, they with the respiratory symptoms. Mhm.
Mhm. Alrighty, we will track that story and make sure that we report on any additional cases or outbreaks. But on that note, thank you very much, Dr. Murphy, for your time, your expertise, answering our viewer submitted questions, breaking down the latest research. It's much appreciated.
Great. Thank you. Have a good weekend.
Thank you. And thank you all for joining us for this week's episode of the Ask Dr. Murphy series. As always, if you have questions or suggested topics, please leave them down in the comments or any of our social media linked in the description. We'll see you next week and have a great weekend.